Good afternoon, everyone, and welcome to the first webinar of the JoinHealth 2025 Spring Series, co-promoted by the Health Cluster Portugal and the IT Health. My name is Sara Pereira. I'm Project Manager at Health Cluster Portugal, and with me, I also have Carolina Diniz co-hosting this webinar, and Carolina is from IT Health in Stars. These webinars are part of the DigiHealth PT initiative, which is the Portuguese Digital Innovation Hub for Health that aims to provide support to SMEs and public organizations in innovation and digital transformation. So, first of all, I'd like to thank and introduce our speakers today. Salomé Azevedo is Head of Digital Health at Value for Health Collab. Her research focuses on designing, implementing, and evaluating robust and efficient digital health services that contribute to high quality care. Salomé holds a PhD in Engineering and Management program from Instituto Superior Técnico. Francisco von Hafe is a PhD candidate in economics at Nova School of Business and Economics. At Value for Health Collab, he serves as an economist responsible for the analysis of financial, political, and socioeconomic data to support the adoption of digital healthcare solutions. Jorge Pinheiro Santos holds a master's degree in medicine from Nova Medical School, and since 2022 he has been a cardiac surgery consultant at Hospital Santa Marta. In 2019, he enrolled in a PhD in Health Sciences, Specialty Medicine in Nova Medical School. So, thank you both for being here and for sharing your experience and expertise with us. This webinar will consist in three parts, and in the first part, Salome will explain to us the concept of value-based healthcare and the fundamentals of value-based pricing. Then, in the second part, we'll have Francisco focusing on concepts related to health economic evaluations and reimbursement models and strategies. And in the last part, we'll have Jorge Pinheiro Santos to share his experience in implementing a value-based digital health service in hospital settings. After each part, we'll have a Q&A session moderated by Carolina Diniz, so please feel free to leave your comments and questions for the speakers using the Q&A tool. I'd also like to say that the recording of this webinar will be available on the L Cluster Portugal YouTube channel. So, to the audience, thank you all for attending this webinar, and we will now move to the first speaker of this afternoon, Salomé Azevedo. So, Salomé, I invite you to start your presentation, and the stage is yours. Thank you.
Thank you, Sarah. I hope that everyone can see the screen. It's okay, cool. So the presentation, as Sarah briefly explained, is connected under the concept of value-based healthcare, but we are going to also focus on not only on the value in general, but also on the cost part in order to understand then how we could establish strategies for sustainable pricing and reimbursement. So we tried that the whole webinar would make sense following these three approaches. I had the pleasure to work with Francisco, and I had the pleasure to work with George in a pilot project that we've been working in Santa Marta under these principles. So looking forward to give you just a brief introduction and then passing to Francisco, which is going to explore the payment models, and then George is going to explore a real world context of these applications. So with no more time to lose in this part, I will start with the first principles and methodologies of cost measuring and why is that important. I always like to start this session when talking about costs under the concept of value-based healthcare, because usually is the topic that everyone thinks. Everyone believes that knows how to talk about it, and usually no one knows how to analyze it, and then starts changing there's misinterpretations in the concept of costing and the concept of pricing. So these are some pictures that were taken from different situations, usually in US, where the population is not happy with the prices and not the costs of developing pharmaceutical products. So, and usually the way that they express themselves usually is misunderstood with also what is involved in the costing analysis. So when we are trying to understand if some organization that is developing further a product or a service in healthcare, we usually have to think about what is the cost of developing that kind of pharma product or services, because if we don't understand the costs associated to that, we cannot say if it's becoming if it's actually evil or not evil, because we don't understand the point. However, the difference between US and Europe in this sense is that actually in Europe there's a whole system behind a social care system behind the price that we assign to a product or a service in healthcare. And on the opposite from US, usually the common citizen doesn't understand that the high cost associated to that price. So usually the price is very low, but the cost is very high. In the US, they don't have the same luck, so they face different ways, and this is something that we have to think about it, that country from country, system from system, price and cost experience a battle that we need to understand the concepts behind in order to talk it properly. So in here, I would like to show you an adaptation from theory of what should be the approach for value-based healthcare, and also how cost faces or fits under this main concept of value-based healthcare. Basically, Rouse puts in a very interesting way. So there's a lot of nodes in the system. There's a system full of nodes, and each node there's a player, and this player plays a relevant role in order for patients to have access to healthcare and providers to provide access to healthcare. So in a way, there's going to be transactions among all these partners, among all these players, transactions of information, assets, care, and all those services that you, as soon as you enter a hospital or as soon as you enter a clinical site, you understand that there's going to be a transaction between players. But what we don't see it, or what is not as clear as it is for the different players, is that actually all the same time there are costs associated to these transactions. So we really need to figure out that everything that is being conducted in healthcare, it has a cost associated to that. Sometimes it's not a cost that we can put a value on it, a currency on it, but it can be a cost of time, right? So healthcare professionals, in order to take care of patients, they also have to spend time with the family members and provide them with the right information so they can support the patients. And all of this, if it's not being taken into consideration in this value-based healthcare analysis, it can jeopardize a lot what we believe it's a service of high value or a service of low value. So in a nutshell, there's different perspectives of the definition of value-based healthcare. While in the US, we are trying to see what is the value in terms of dollars that we can improve outcomes for the patients in the European Union health-related systems. We have to figure out that we also have to include equity and the social part of the distribution of the resources. So I always like to think about this kind of network proposed by Rose, which we see all the players in the system and try to understand the different transactions that are incurred to that. So as I was saying, also, I really like cartoons because it also translates in a very with a very simplistic way the different interpretations of what can be a cost on a transaction. As I was telling you before, it can be time, and it can be not only cost but also time. So the time dedicated from the healthcare professionals, or the time that a patient takes from as a work leave in order to go to an appointment. Everything matters in order for us to understand if we are actually driving the value-based healthcare principle or not. And the agenda for today is going to be a little bit. I'm going to do like a records. It usually is a 1 hour and a half for this topic. I think I will only have 15 minutes to do it, but it's to give you general principles of what you have to think about it if you are a healthcare professional and you want to present a new health intervention to the administration board, or if you are a patient and you want to understand why there's a certain bill and what should be the cost behind that bill, or if you are from pharmaceutical companies, actually what is the different interpretations of price and costs behind a transaction within the healthcare system. So we're going to look forward for how we can measure costs actually in the healthcare system. We're going to look at some terminology and some basic concepts in order for us to all talk about the same things, and then we will cover a very quick overview of like if you wanted to conduct a cost analysis study, what you should take into consideration. And I hope it's still funny, because usually the most funny part is usually the one from Francisco and George, and then usually the not lucky one to present the worst part. But so I like to try to impress people in this part. So actually, we can also try to save the healthcare system by look at costs, because looking at costs and analyzing costs is like when we are at home trying to make out to analyze our budget for the whole month, right? So in the healthcare system, if we look at costs, we can actually help decision makers define priorities of new interventions, decide new technologies. Usually, from what I see a lot, is when someone comes with a great idea to the administration board, it's rejected because they never presented the costs. And cost is important because it's one of the variables that decision makers take into consideration in order to adopt or reject a certain health intervention. Also helps the managers to understand how they can plan and allocate budget, and also ask for or reallocate resources and bring more resources to the departments in need or to the patients in need. And also, of course, it's a matter to us understand technical efficiency and then try and improve the overall cycle. So what I see usually in the healthcare system is that either people hate to talk about costs, or they love talk about costs, and they only talk about costs. If you can learn anything from me today, is that it should be a balance. So costs should be there. We should not be afraid to talk about them, but it doesn't reduce to that in the concept of value-based healthcare. So huge misconception from a lot of people while we are talking about cost measurement and trying to do a cost analysis in interventions is confusing cost with pricing. And costs, you always have to think in which perspective are you talking about costs, because for healthcare providers, it's the expense incurred in delivering healthcare services to patients. For payers, which are not the providers most of the times, is the amount they pay to providers, so to healthcare providers, for the services to be delivered. And for patients is the amount they pay out of their pockets to pay for the services. So it's costs must be always concerned in a perspective of someone that is going to incur an expense, which might be similar or completely different from the pricing, which is going to be the amount that is going to be charged for a good or a health service or a medical bill. And then the reimbursement, which is another, I think it's the third most important concept within cost analysis, which is the reimbursement. And basically consists in a payment made by a third party, imagine an insurance company, to a healthcare provider. And there's different ways of doing the reimbursement. Francisco is going to take care of this and help you through it. But I think this is the part where everyone, or at least all of us, are trying to explore and do research on this, is how we can make reimbursement fair to all the players in the system, as I was explaining you in the previous slide. Then the differences between fixed and variable cost. I don't want to go very deep on the components, but they are very important if you are not from economics or management to understand a little bit that these kind of concepts affect the way that you present the costs of the intervention that you are planning, or the service that you are trying to acquire, or the product that you are trying to develop or sell. So understanding the difference in a nutshell for between fixed and variable costs is that fixed usually are fixed over a long term, and we can fix a time frame in the analysis, and we say, well, this is going to be fixed for a year, and it's just going to be changed. The value is just going to be changed in 1 or 2 years that later. Variable cost is in the same time frame. You'd see a lot of changes on variable costs. So if you think about your home, I always say this to our students, it's actually very easy, and it's the same thing as in the hospital. So the rent is going to be a fixed cost because we believe that our landlord is not going to change in the scope of a year, and then the water billing and all the expenses concerning electricity and supplies, it's going to be a variable cost because it depends on the quantity, it depends also on the price of the market, and it can change a lot. So if you are running a hospital, or if you are running a research and development department where you are actually coming up with a new service or a new healthcare intervention, that's something that you have to consider, and looking at your resources and trying to come up with this basic split of analysis. Then the total cost is also, of course, the sum of the fixed cost and the variable cost, considering a time frame zone. Then the most important ones, the variables, which is the marginal and the incremental cost. The marginal cost is the additional cost that we will have when we decide to increase 1 unit to our production. So we decided that we did our analysis. We were able to understand that we could serve 100 patients per day, but then there's something happens. There's a huge catastrophe, and then one more patient comes, and we were not expecting that. So that's the cost, the marginal cost, and usually is the cost that is most relevant for our analysis, because that's the uncertainty of taking care of all these people and being able to produce to supply one more patient, but with minimal cost. And then the incremental cost is, okay, so I have this new technology, or I have this new intervention that is a patient monitoring service, and I want to add that to the hospital portfolio of services, and how much is going to cost adding this new intervention. So if you are an innovator, or if you are an entrepreneur, or if you are the head of any kind of department that is trying to come up with a new service or technology in the healthcare system, incremental costs should be on your analysis. Then what we usually do for any study, and it can become a very simple study or a very complex study, is that we split this in 5 phases. The first phase, we define the problem, and we understand for whom. So what are the stakeholders for whom that I'm going to compute the cost. And because if I compute the cost for the healthcare system, is going to be different from the patient perspective, or the healthcare provider perspective, or the insurance company perspective. And that's something that you should always start with. Like, I'm going to conduct a cost study analysis. The first thing that I'm going to do is to figure out to whom am I going to show the cost. Because if you select the wrong perspective in cost analysis, you will lose the whole negotiation part of trying to be accepted, or by the administration board, or whoever takes the decision. So figuring out what is the perspective from whom you want to compute the cost is actually really important. And it's very funny because it's usually when I have time to do an exercise with the participants, usually they pick the wrong perspective all the time, even though I start with this claim. So be careful with this, and we can talk in the Q&A if you don't understand it really well. But I'm in 1 or 2 slides, I'm going to show you the different perspectives that you can go. And then the second part is usually, again, one of the huge mistakes in all the cost analysis that I've seen is not defining the start and end of the time frame that I'm going to analyze the service or the intervention. So people usually start collecting costs and analyzing costs in groups or teams, and everyone starts and ends the analysis in different times. So it's important that you first do that, and if you do that, the problem is completely defined, and the rest is kind of easy. So the second stage is to identify the type of costs, and in here it's important to collect information as accurate as possible. But for everyone that have done these cost analysis studies, know that it's almost impossible to find real world data about the costs, because it's either very private and confidential, so not accessible to all, or the public available information, it's not very accurate because it depends in a lot of negotiation terms with both the supplier and the buyer. So all collecting the information sources and understanding that the unit cost of different resources requires several methods that I think I'm also going to have time to show you very quickly, where you start listing the different types of items or resources that you have and figuring out which are the most relevant and accurate sources. Then the third part is usually the funniest part, or at least for me, it's where I have actually fun, because it's actually when I start measuring the costs in different perspectives and making different assumptions in order to have the most how do I say, a meaningful value of the cost of the intervention or the technology that I'm analyzing. And then I have to adjust to the present value because, well, we know that economy influences a lot the way that the value of the prices that we buy our supplies, also the inflation, and so we need always to consider that my proposal is going to be analyzed in 6 months or maybe 1 year. So I have to figure out and show to the decision makers how that cost that I was computing in that day is going to be affected in the future. And then we aggregate in different terms, and that's also very easy and the funny part of it. Considering the costs and perspectives really quickly is that you have there are more, but you have main four. The social perspective, which includes all costs and effects, and it doesn't matter for who is paying. We are focusing in terms of society. What is the assessment of the costs and the benefits of the intervention? Then, from the healthcare system perspective, it's usually either the hospital or the center which is incurring or providing the services, and we want to figure out what are the costs for them. And then we have the payer perspective, which can be the government or it can be an insurance company. And in this way, we need to understand that the costs are also completely different. It's not going to be the same costs as the healthcare system that has to pay for the healthcare providers, space, rent, and so. And then you also have the patient perspective, which is trying to understand the cost that the patient will incur in order to have access to that kind of service or technology. So as I was telling you before, it's really important to figure out these perspectives and understand then how to present that to the payer, because the payer is going to pay the price. So these three perspectives will tell you in the end who is going to be the payer. Okay, and also the different types of costs that each perspective has. Now, identifying costs in a nutshell. So you have direct healthcare costs, which is with the facilities, treatment care and medication and procedures. Then you have direct costs that are not related to healthcare, which is like transportation, childcare, and this is usually costs that are incurred by the patient, which is like when he has to go to an appointment to receive care. In oncology, you will lose 1 day of working, and that leave day is either, if it's not reimbursed, it's out of pocket money that we have to consider. Then productivity costs, which is also associated to the economic productivity loss due to death. And then the opportunity cost, which is a little bit tricky to understand, but it's something that it's a cost of losing something that you discarded in favor of another alternative. So you have to think, okay, I could have I have two choices, choosing A or choosing B as treatment, and the opportunity cost is the cost of losing A because I chose B. And it's a tricky one, I know, but I don't have time to go further on this, and usually it takes like 15 minutes just to go for this. But it's an important approach to think about it, because when we are selecting interventions and healthcare interventions, we are going to always have opportunity costs. We are going to always lose something because we are deciding between two alternatives. Of course, one is better than the other in some terms, but in other terms are not. So this is kind of the deal of using opportunity cost to help us support our decision. Then, considering costing methods, we have the micro costing approach and the gross or average costing. The micro costing approach is a bottom-up approach. It means that we look at every kind of activity that or resource that we are using in an intervention or in a treatment or wherever, and we start summing up the costs until we have a clear vision of the cost of the full intervention. Well, in the other alternative, we come up with, okay, it's more or less a total budget allocated to a specific department, and this department has more or less 100 patients getting this kind of getting these three or four different services, and we split or we divide the total cost to the services that we are providing by the department. These two approaches are not mutually exclusive. Actually, in real life we combine both of them, and we make assumptions every time that we are trying to mix both approaches. Going for one or another loses a lot of things, so it's really important to go for it. Then, in a spectrum of the different costing methods, we have the famous time-driven activity-based costing, which is called in very short TDAVC. And this one is very useful because it's very precise, but it's in other ways time-consuming. So this method should be used when you are actually trying to propose a new intervention or a new treatment, because it's going to help you designing it in a very approachable way. The activity-based costing system, it's very similar to the first one, but it doesn't consider cost. Actually, TDIVC, it's an evolution of the activity-based costing system. And then the cost adjusted to price or total reimbursement is closer in the spectrum to gross costing, but the costs involved are adjusted based on the price / reimbursement ratio. So it's important to understand that the cost is going to be as a direct relation to price and reimbursement. And usually this only happens in the US. I'm not very familiar with this method. I don't use it here in Portugal and in Europe. And then we have the gross costing, which is really easy to implement. It's important to use it when you don't have enough data to go for TDAVC. But you have to also consider that it doesn't consider the different patients' profiles and the different types of interventions that they might incur. So easy but unprecise. Then considering data collection methods, we have on your left the two types of approaches, and usually I combine both. The first one is considering the resources used. So I compile all the information on the quantities and prices of the resources. And the second approach is going for the expenses. So basically looking at expenditure reports and understanding which kind of expenses were reported as official of an appointment or a phone call or an X-ray. And I try to use them to have the most relevant data concerning the unit costs. Common data sources are administrative databases, if you can get them. For me, it's usually very hard to get them because they are very confidential data. It's very confidential and it's under it's not public, but also you can use questionnaires and ask healthcare providers to have to give you a perception of what would be the cost, because usually they are more in touch with this kind of information. So they it's always a perception, but it's better than also just looking at online sources, and you can compare them then. Then in here, you have to adjust to present value, and then you can go for capital cost estimation, which has to consider that equipment is going to lose value over time, and there's methods to apply to consider depreciation of that. So when you in your cost analysis you include a computer or some kind of equipment, you have to consider that after several years that computer doesn't value as much, so all your assets are losing their capital value. Then, as I told you before, inflation. So guaranteeing that we know how much a euro values today and in 5 years, so we totally show to our decision makers what is going to be the impact in terms of costs of an intervention in 5 years long, because it's also a very short period, but there's some kind of treatments that you need to wait for 10, 15, 20 years to understand the impact. So having this kind of analysis helps you making better decisions. And then discounting also, which is also related to the time changes in the real value of the assets in the terms of the cash flow. Sorry. Then you aggregate, and in the aggregation part, it also depends on the perspective of the decision maker that's in front of you. Sometimes in terms of certain interventions like remote patient monitoring, looking at human resources related costs is important, so I can aggregate and categorize by allocating resources. Sometimes concerning, imagine, new oncology treatments, it's important to see which kind of activities within the whole treatment are more costly than others, so we can try to improve them, or we can try to make it more efficient. Or if we are looking from a hospital perspective, we can look for departments and cost centers. So it helps us understanding what are the departments that take us most costs. In a nutshell, because I'm almost passing 5 minutes from my time, I think, or 1 minute, I don't know, but I think I'm okay. Okay, so the key takeaways in this is that cost analysis can be actually conducted by anyone. So I always teach this to healthcare professionals, and I believe they are the best students on this, because all their work is influenced by this daily, because a lot of their decision makers are always asking them about the costs and thinking about the costs. And this kind of exercise can be really important for healthcare professionals to have a stronger and more influenced voice with the administration boards while taking decisions considering healthcare interventions design. So first, defining for whom I'm going to compute the cost, through what time, what is my time frame of analysis, what is the intervention that I'm looking at, which kind of resources and activities are involved in this intervention, and then collecting the most accurate information concerning each unit cost. Yes, and then I'm going to connect this to Francisco. So in the next session, in the next part, cost measure can be used in economic evaluations and as a support tool in defining payment models. So actually, when you have the cost, which is the most tough part, then you can have a lot of fun in economic evaluation. So I will also leave that part for Francisco, and I'm open for your questions now.
Thank you, Salome. Can you hear me?
Yeah.
Thank you for your informative presentation. We have now time for some questions, and we actually have one here that I'll read to you. So it's from Emmanuel, and he says, "Hi everyone, Salome. What is..." Well, there's actually two questions. So the first one is, what is the accuracy of TDABC in cost estimation when compared to activity-based costing?
Beautiful question, actually. Very theoretical, but so I'm going to try. So in a way, time is the TDABC is going to be more accurate because it takes into consideration a variable that activity-based costing doesn't consider, which is time. So what we do in TDABC is that as ABC, we split the process in activities. And we also, instead of just summing up the costs, we consider the time that the resources were allocated to that specific activities, which is even better than before because now we have a more precise analysis about the cost per hour that each resource was allocated to a specific activity.
Okay, and the second question is, why is it preferred over gross costing?
Yeah, well, it's preferred in certain situations, right? As I was telling before, it's preferred when we are designing a new service or when we are designing a new intervention and we don't know a lot about it. When is a service that is already that we have a lot of historical records? Gross costing is used because it's easier and faster, so it can provide us with an average value that it can be acceptable. So TDABC is more used when we are developing new services or new proposals, and we really want to figure out if it's going to be more costly than the alternative.
Thank you for answering the questions. As we do not have, I was just checking any more questions for you. Let's now dive into the second part of the webinar, where Francisco von Haff will cover concepts related to health economic evaluations and reimbursement models. So, Francisco, I invite you to start your presentation.
Sure, I'm just sharing my screen. Hopefully you can see it now.
Yeah, we can.
So, good afternoon, everyone. My name is Francisco, as I was already introduced. I'm a researcher here at Value for Health Co-Lab, and I work very closely with Salome in this type of studies. And I'm also a PhD student in economics at Nova SVE. First of all, I would like to thank to my co-lab team for the opportunity to present the second part of the webinar. And also would like to thank Health Cluster Portugal and EIT Health for organizing this webinar and the webinar series. In this part, I will talk a little bit more about value-based pricing and reimbursement in healthcare. So in a nutshell, my presentation is going to be basically divided in two parts. So the first part with a deeper focus on economic evaluation, where I'll try to talk about the importance of the economic evaluation, what questions should you consider when doing one, and how to choose the type of economic evaluation, and then introduce a concept of willingness to pay in this sense. And then I'll move to the cost measurement and, to use the cost measurement and all the results that you obtained so far to define financing models and payment models with a zoom in value-based payment. So why are economic evaluations important? And this part, I will try to convince you about why you should do it. So first of all, economic evaluations will help us to compare different healthcare interventions. So in a more structured and a more pragmatic way. So it will be very relevant to make sure that we do not forget an important step, or at least that it reduces the chance for us of forgetting to do a relevant step. One of them, as Salma mentioned in the previous presentation, is about the definition of the relevant alternative to which we want to compare our new program to. That's a very important part. That alternative can be the current practice or can be any other, but it should be very clearly stated from the beginning of the study. And second of all, it's important also to clearly define the perspective to which we are doing the economic evaluation. Could be, again, the patient, the hospital provider, can be the Ministry of Health, the government. It has to be super well defined because it can influence the results of the healthcare, of the economic evaluation. And then if we do not rely in these more structured and pragmatic methods, probably some results that will reach can be a little bit misleading, can be biased, and ultimately not leading to the best allocation of the scarce resources that we have in healthcare. So using economic evaluation, a more formal tool, will be able to be more transparent and more clear about the process and make better judgments about the value of the money that we put in place. So overall, economic evaluation may not change the decision that it's going to be made, but it will improve the way that the decision is made and will make sure that all the process is much more clear. And now that I hope I've convinced you all of the importance of doing economic evaluation, I'm going to highlight some questions that we should try to answer when doing one of these studies. And the first one is the definition of the objective of the economic evaluation. It can be one or more, but it should be stated what we are trying to evaluate and the objective of the study, even though that objective can change throughout the study. Then we'll focus on how will the costs and the consequences of the intervention be evaluated, considering the evaluation strategy. Again, it can be defined at the beginning and can be iteratively changed throughout the study. And then what is being evaluated? And to this question, I will answer with 4 more questions. So first of all, it is relevant to define which health outcomes will be evaluated. Are we considering, for example, the number of cases avoided or the disability avoided or variation in cholesterol levels? This should be defined at the beginning. Then what intermediate outcome indicators will be included in the analysis? Is it the number of individuals treated, the target population that can be reached by the intervention, for example? And then which operational indicators will be included in the analysis? And here we could use, for example, a quality indicator or the number of individuals who drop out of our study. And finally, building on the previous presentation, which costs will be included in our economic evaluation analysis? Will we just focus on the cost of the intervention, or we try to broaden our perspective and also include the cost that the intervention may save, for example? So defining these questions when doing a study is relevant to be in a more structured way. And finally, how are we going to present the results and how are we going to use the data also needs to be addressed. So I will now move to how to choose the type of economic evaluation. And again, as in cost, that the answer to this question heavily depends on the data that you have available, on the data on the costs and on the data on the effectiveness of the intervention. Because sometimes we may not have access to the data of the effectiveness of the intervention. And in this case, we should focus more on a costing study. But if we do have access to the effectiveness of the intervention, probably we should first see if the effectiveness is similar or the same across the different alternatives that we are considering. And if so, a cost minimization study would be a suitable one. But if they are different, then we can ask a couple of more questions. Namely, can the outcomes be valued in monetary terms? And if the answer is yes, a cost-benefit analysis would be a good approach. But if we could evaluate the outcomes using, for example, QALYs, we could do a cost utility analysis, and if not, a cost effectiveness one. And now I would like to talk a little bit about this valuing the outcomes in monetary terms. And this is possible using, among many tools, willingness to pay. So willingness to pay is basically a concept that was developed in environmental economics and then adopted by health economics, and it will allow us to attribute monetary values to typically things, let's call it like this, that cannot be exchanged in the market. And they basically represent the maximum amount of money an individual or organization is willing to pay for a certain outcome of the of the intervention. And this process of attributing this monetary value to outcomes will actually help us in the definition of pricing strategies or reimbursement strategies in our healthcare, in our analysis. But again, it's important to state that different stakeholders might have different perspectives on what they value. So it's always important, as I mentioned, for the perspective that you choose in economic evaluation, to also keep in mind that different stakeholders might have different concerns regarding their willingness to pay. For example, patients might be more concerned regarding the health benefits that an intervention might lead, or payers might be more worried about the impact of the intervention in the budget, or the government about the impact of the intervention on the access to healthcare. So willingness to pay actually varies across stakeholders, and it's important to understand their perspectives for pricing decisions, reimbursement decisions, and policy-making decisions. And just a side note to tell you that most of studies typically focus on the willingness to pay of patients and typically often overlook those other perspectives, but it's important to consider them because some of them are the key decision makers depending on the type of healthcare system that we are in. And how can we attribute these monetary values? So willingness to pay can be, the methods for measuring willingness to pay can be divided in basically two major groups. So the first one is the direct methods, more focused related to stated preferences. So basically, we ask individuals about their willingness to pay, and this is commonly easier to administer and commonly, just a note there. And but what a person is willing to do might not actually represent what the person is actually going to do, and that's important to keep in mind. Some methods include, for example, a contingent valuation, where scenarios are presented to the respondent, and we can ask yes or no if we pay or not, or we can do a more bidding approach with them, or we could do discrete choice experiments where we present different alternatives with different attributes and let the respondent choose. In the indirect methods, we can infer the willingness to pay from the actual behavior of the participants, so of the agents. So basically, it will reflect their real-world decisions, but commonly this data is a little bit more difficult to obtain, and sometimes it's harder to understand what factors led to that decision from the agent. So some methods may include observe the spending of the agents, or use variations in market prices and try to relate to the specific attributes. So overall, using willingness to pay in healthcare is relevant for us to define sustainable price points and inform reimbursement models. Will help us to allocate budget and help us to estimate the demand for new treatments or medical technologies. And as you've seen so far, I've been talking a bit about reimbursement, payment models, and that's exactly where I want to go now in this second part of the presentation. So healthcare financing plays an important role in ensuring access to care and while maintaining economic sustainability. And these two concepts that are highlighted in the slide, efficiency and equity, are super relevant to that. Efficiency is focused on guaranteeing that outcomes are that we are maximizing the outcomes with available resources. And equity focus is related to ensuring access to everyone who needs healthcare. And we often rely on these public or private insured mechanisms, solidarity mechanisms, that help redistribute the resources from those who are healthy to those who are sick, and basically help to make sure that when a person faces a certain health shock, that person will not run into catastrophic healthcare expenditures and be able to receive the necessary care. So good financing in healthcare ensures that care is going to be affordable, efficient, and fair. And that's the idea that this graph here tries to capture. As you can see, the population that provides funds to the financier that then pays for the healthcare provider who provides care to the population. And this cycle goes on and on. And regarding sustainability, so to ensure the financial sustainability of payment of the financial sustainability of the healthcare sector, payment models should support the quality of care and the system efficiency. So first of all, and as Salma mentioned in the previous presentation, it is super important to define what are we paying for. So are we paying for the visit? Are we paying for the diagnosis? Are we paying for patient that gets treated? This has to be defined at the beginning, and also it has to be, the payment should try to cover as much the costs that were incurred by the healthcare provider. So overall, sustainability includes the efficient use of the resources, covering the provider's costs, and ensuring access to everyone. And with this in mind, I would like to show you this graph where we put different means of paying for healthcare services, starting for ones with less incentives for quality assurance and results control that may lead to higher waste and inefficient use of resources, and finishing with the ones that propose a more importance, that pose more importance to quality control and value creation for the patients. So starting, and this definition actually impacts how the providers will behave and how much importance they will provide to the quality of the care that they provide. So fee for service is the first on the left, I believe. So it will pay basically for each service that the healthcare provider provides, and it can lead to some overuse of the resources and consequently to some waste. Case-based reimbursement, DRGs, that's what we have here in Portugal too, is basically paid per condition. It is efficient, but it might encourage volume and might not take into account the variation in the patient's needs. Then capitation, so basically it pays per patient that is assigned to the hospital. Let's say it might lead to neglecting some more complex and more expensive care. And finally, bundle payments, who pay one price for the full episode of care, encouraging care coordination, but again, not taking into account this variation across patients. So as you probably noticed so far, I've not mentioned anything related to outcomes or to quality of the healthcare that is being provided. And that's exactly the shift that value-based payment brings to the table. So the methods that I presented so far typically focus on volume over quality, might lead to unnecessary procedures, incurring higher costs, and do not account the quality of the care that is being provided. Whereas value-based payment will now focus on patient health improvements instead of volume, will encourage more preventive care and chronic disease management, and will align financial incentives with the outcomes. And this idea is actually expressed here in this table. We have these key 4 components of value-based payment models. So first of all is the performance and metrics and quality indicators. So the payments must be tied to measurable health outcomes, which may include hospital readmissions, for example, or reduction in hospital readmissions, improving the management of chronic diseases, improve patient reported quality of life, for example. Then there is a risk sharing and incentive structures put in place. So if the costs, if the provider can increase the quality of the care that is being given without, and at the same time reducing costs, he will earn some bonuses. But if you will achieve poor outcomes, then you will get lower reimbursements or penalties. But it's also very important to keep in mind that we should always take into account patient variation and case mix adjustments to make sure that we are comparing the same things across the providers. And then all the decisions are made using data. And Salman already talked a lot about how the different sources that we can use, and requires also this collaboration between the provider and the payer, okay, to define fair compensation structures and actually guarantee an equitable access to high quality care for everyone who needs to access care. And throughout the world, as this table summarizes, there are some case studies where this has been implemented. So for the United States, we have bundled payments for joint replacement. So we can see the reduction in spending per hip and knee replacement episodes without this increase in complication rates. For the United Kingdom, we saw a change, an application of pay-per-performance for general practitioners, where we assisted to a reduction in the mortality. For the German case, we saw in this disease management, we actually did not lead to any important changes, but the confidence intervals are too broad yet, so we need more studies to actually be able to understand the actual impact of these pay-per-performance. So just to conclude, and I think I'm still on time, just to share with you that economic evaluation is important. We should always be super clear about our study objectives, the outcomes that we want to measure, and to whom we want to present the results to. Then healthcare finance actually is very important to balance the efficiency and equity in the payment models, and willingness to pay is a relevant method that we could use to assign monetary values, always keeping in mind that difference according to stakeholders. And finally, concluding with this important idea of using value-based payments where we connect the cost part and the quality part that are super relevant. So thank you very much for your time, and now I'm willing to answer all questions.
Thank you, Francisco, for your presentation and for sharing your expertise with us. We have one question that is actually a very overall question, very interesting. That is, if we are trying to write our own startup business plan, which type of cost shall we consider?
This is the $1 million question, I would say.
Exactly.
But it's important to keep in mind what we are trying to keep in mind, the solution that we are proposing in our startup, and see the impacts that it might have. So depending on the person we are pitching our business plan, it would be important to adapt the cost information that we are providing. For example, if you are trying to convince insurance company to fund our solution, we should focus on the impact on the budget, on disease prevention, how much they can save. Or if you are focusing on patients, probably how can they save money for not going to the hospital? I don't know. It will always depend on the technology and or the solution that is being presented and to whom that is being presented. So keeping a broad perspective is important, and considering everyone too.
Thank you. And the second question that we have is from Renata. And Renata thanks you for the very interesting presentation and asks, what are the key challenges in defining an appropriate willingness to pay threshold for innovative health technologies?
Yes, that question is also very relevant. We know that in some countries thresholds have been defined. So I actually, to answer that question, I believe that it's, again, not a number that we can provide, but I believe that more important than defining the appropriate willingness to pay is actually to define what factors influence the willingness to pay for the different stakeholders for that solution or intervention that is proposing. Understanding what is behind their decision, it's actually more relevant and will help us to target the needs of the different stakeholders than to look for a specific value. That I think would be my answer to this challenging question.
Questions. Thank you, Francisco.
Thank you very much.
Okay, no more questions. So thank you again for your presentation. Let's now dive into the last part of the webinar. Jorge, I invite you to start your presentation whenever you want.
Okay. Hello, everyone. Can you see my presentation?
Yes, everything okay.
Okay. Thank you so much. So my name is Jorge Santos. I'm a cardiac surgeon at Hospital Santa Marta in Lisbon. And first of all, I'd like to thank the opportunity to present my perspective and our case study of what we did regarding telemonitoring and cost analysis with you all, and to say that it's really an honor to be speaking with an audience of people that are interested in this kind of issues that seem to me very relevant in the healthcare perspective, in how we can improve our conditions to our patients. So I'll talk to you. I'll make a, sorry, but it's not. I'll make a brief introduction about cost effectiveness in cardiac surgery and cost analysis in cardiac surgery, and then I'll dive into what we did with our digital health service. So, first of all, it is important to know that every day healthcare is getting more and more expensive, and the people that govern us, the Ministry of Health, and also other shareholders and stakeholders, are keen that we spend our money the more efficiently possible and creating value. That is, we have to allocate our resources the best way possible. So, evaluating cost effectiveness in cardiac surgery in particular, but in health in general, has become more and more critical. We also know that in cardiac surgery, every day there are appearing new devices, and some techniques tend to appear from time to time, and that is per se an enabler of cost effectiveness analysis in cardiac surgery, because we need to know that if the new devices and new technologies we're applying to care of our patients, if they're going to be effectiveness and if they're going to reduce everyday costs. And this kind of analysis has become more and more relevant, even that some international associations like the American College of Cardiology and the American Heart Association have started recommending in their clinical guidelines that cost effectiveness analysis should be a part of evaluating our possible new treatments, not only clinical outcomes, patient experience, but also cost effectiveness as a measurement of the utility of the different therapeutics that are developed to our patients. And not only clinicians, but also payers are critical for effectively and efficiently allocating society's healthcare resources and maximizing value through evidence-based decisions. We also know, unfortunately, that we live with constrained resources. We don't have money to pay for everything that we want. So, those who pay must consider value when they're going to decide if they're going to cover or reimburse certain expenses regarding especially new surgical interventions. In Portugal, with the public health system, that doesn't seem to be such a pressing question right now when we compare with private hospitalization and the model of health insurance and health insurance reimbursement. But if we want to manage a budget that is limited and has constraints, we have to know that we're going to put our money where we are sure that it's going to be more rewarding for our patients. So cost effectiveness analysis in cardiac surgery faces some methodological challenges. Our interventions have high upfront costs and risks. That means that patients are going to go into an OR and going to be submitted to a surgery that has a risk of death that is considered important, not only for the patient, but also for society. And these interventions, as they always require a stay in intensive care units and some kind of hospital stay after that, they have been studied to demonstrate that there is a high investment that is necessary to operate on a patient. However, this high upfront cost may be offset by long-term gains in survival, quality of life, and reductions in morbidity and healthcare resource use. If we treat our patients and if we treat them well, they will resort less to healthcare, and then they will spend less of our healthcare budget. And cardiac surgery is also innovative. That means that we develop new devices, we modify devices, we change surgical technique, we advance from classical to mini sternotomy to robotic surgery. We select patients more and more to tailor our approach to the more appropriate approach for these patients. And every day there are always evolving changes in how we manage these patients in the post-operative period. So we are always trying to innovate, to do better for our patients, to try to have better results. And that means that as cost effectiveness analysis may be stuck. I won't say stuck, but it may be limited to the evaluation if this process is ever changing, how we may not capture the right picture at the right time of how the procedure can be cost effective. So it is important to every time we do a cost effectiveness analysis to take into account sensitivity analysis and reassessments regarding possible changes that have been made in the treatment that we're analyzing. We also know that cost effectiveness analysis is designed to give answers for the average patient receiving average care. However, there is an increasing individualization of care. That means that if we refine our cost effectiveness analysis, it will provide results applicable to the individual patient. So we'll be more and more able to see that these patients that will be submitted to this procedure will this be cost effective and not only for the average patient, because every day the patient profile is changing and we can't capture it all. So individualized cost effectiveness analysis may lead to improved patient selection and guide personalized medical decision making. And like that, we will be able to optimize the value of care. We know, however, that improving costs while simultaneously enhancing quality can be challenging, and that if we do innovative techniques in the absence of quality improvement, it will lead to increased complications and costs, and that will be not cost effective at all. When we talk about cost analysis in cardiac surgery, we know that when we estimate effectiveness and the value of a given therapy, we must illustrate improvement in clinical outcomes and patient experience, namely quality of life. Unlike it was 30 years ago, 20 years ago, where the only focus of medical research would be mortality, since then we have evolved a lot, and it is important to not only value mortality, because it is, after all, the main concern of our patients if they live or if they die after a procedure, but we also need to value how will they be after the procedure if they live, and how it will impact their quality of life. And that whole patient experience, not only the clinical outcomes, but also the patient-related outcome measures, they will contribute to the value that patients and the healthcare system will attribute to the surgery we're going to perform. So as my colleagues Salome and Francisco have brilliantly presented just a few minutes ago, estimating actual costs is really difficult because there is an interplay between the actual and estimated direct and indirect hospital expense. There's also case mix index to take into account when you do these calculations, and the charge capture according to diagnostic related group can change, and it will lead to difficulties in calculating the costs. So the TDABC, as Francisco and Salome have mentioned, is a costing methodology that can be mapped directly to the actual patient-specific episode of care and may present a more precise accounting for the actual costs incurred by the specific patient encounter. This graph that I bring you comes in line with what Francisco said, that payment methods should support quality, and that if we don't improve quality while leading with innovation, we will incur in a highest expenditure. So our target zone will be here, where innovation costs is improving, but also total quality cost is improving while complication cost is decreasing. So Now I want to talk to you about CardioFollow AI. This was our clinical study that we developed at the cardiac surgery department of Hospital Santa Marta in ULS São José. It was a partnership between our clinical service, also the Value for Health Collab, and Fraunhofer. And it was a project funded by Fundação Ciência e Tecnologia. It was, in its base, an improvement of a unique follow-up program in cardiac surgery in Portugal. Hospital Santa Marta is the only service of cardiac surgery that has a follow-up program that has been in place for over 10 years, and it's mainly nurse-driven, that we follow our patients throughout the first post-operative year, and we study quality of life, medication adherence, changes in lifestyle, and so many other things. So the primary outcome of our study was to see if adding a digital health service could help us detect more critical incidents by patients and measured by the clinical team. And also our secondary outcomes were to detect complications, program adherence, interactions between the team and monitored patients, to measure costs and to measure patient satisfaction. So we recruited patients from March 2022 to September 2023. So we selected adult patients submitted to cardiac surgery that we were able to interact with a smartphone, and resorting to a machine learning-based algorithm for the prediction of the development of severe complications, we divided this patient group into two groups. One group that would be submitted to the standard follow-up, so medical appointments at 1, 3, 6, and 12 months, and nurse follow-up that will be constituted by phone or in-person interviews 3 days after discharge, and then at 1, 3, 6, and 12 months after surgery, similar to the medical follow-up. And we compare them with this second type of service that would be the same standard follow-up, and then the usage of a home telemonitoring kit for 90 days. This kit was, as you can see here in this picture, would be constituted by a scale, a sphygmomanometer, a digital watch, and a smartphone. This smartphone would have installed an app that would ask for heart failure signs and symptoms, wound alterations, and would ask patients to take an everyday picture of their wound so that we can monitor the healing process. Everything this kit collected daily, it would then migrate to an online database where a team of nurses and doctors would be able to monitor remotely our patients and check for any deviation to the normal post-operative periods. So I would briefly bring you some results that we had in terms of clinical complications. We had some, both in the digital health service, both in the standard of care patients, and this was not different between the two groups. What we could see in the patients that were subjected to the digital health service is that we had a lot of actions and interactions between the clinical team and the patients, and that most of these interactions, as you can see here, were related to patient education and enlightening some doubts that arisen during this clinical study. However, we did some medication adjustments. We had to anticipate some appointments. So it was interesting for us to see that we were really interacting with these patients. Regarding our cost analysis, we could see that this program, these digital health services, led us to, sorry, give me just 2 seconds. Really sorry. So as I was saying, this digital health service led to an increase in costs for the health provider when compared to the standards of care patients. And this cost increase was mainly due to an increase in human resources necessary to follow our patients and to respond to their needs. We also were able to compute where these healthcare professionals were needed during this clinical pathway, and that we, as our follow-up, really depended on the nursing staff. We would see that nurses were the group where there was a big increase of time spent with this digital health service follow-up when comparing to the standard of care patients. However, all professionals were significantly increasing their time in regard to patient interaction in this digital health service, and also patients in themselves were more involved and spent more time caring for their health. And we believe that this would lead to an increase in patient literacy after this program. And we, as you can see here, also, as the digital health service patients had an increase in consultation appointments uh, when we saw everything that was going on with our patients regarding the wound, regarding any questions that they have regarding medication, regarding everything, we see that was also an increase in expenditure when we talk about these patients that were followed with the digital health service. So we verified that there was no clinical difference in outcomes between groups, mainly because there was a low incidence of complications in our sample. We used a risk algorithm based on artificial intelligence that allowed us to select patients with a higher potential of complications, and hopefully that will lead to resource allocations to patients with a higher potential of healthcare service use. There was a big number of interventions of the clinical team in the digital health service group, as I've shown you, and most of these interventions were related to patient education, and we believe that it will increase patient literacy. Also, the median cost associated with the patient pathway was approximately 170 euros higher in the digital health service group. And this cost primarily can be attributed to the additional time spent by human resources. So in conclusion, this was an innovative program on a national and international level with replicability potential in other cardiac surgery departments. It was a multidisciplinary approach between o ULS São José, Universidade Nova de Lisboa, and technological stakeholders such as Fraunhofer and Value for Health CoLab. Home telemonitoring is a feasible and safe method for following patients after discharge after cardiac surgery. This kind of digital health service with telemonitoring allows for a greater access to healthcare, allowing for value-based resource allocation. Telemonitoring can be used as a tool to reinforce patient education in the postoperative period and in secondary prevention after cardiac surgery. And finally, these patients receive more individualized care and have multiple interactions with the clinical team, reinforcing health literacy and patient safety satisfaction. And this was everything I had to talk to you. Thank you for listening to me.
Thank you, George, for your explanation. We have some questions here for you. So I'll start with the first one from Raul. The individualized CEAs is not going the opposite direction of evidence-based medicine? If yes, what is the impact of recreating years of healthcare pathways definition?
So evidence-based medicine show us how to treat the majority of our patients. However, our patients more and more deserve and not deserve, but they, how do you say this in English? Exigem.
Demand.
They demand that healthcare is tailored to their needs. So although evidence-based medicine should allow us a big framework on how to take care of our patients, more and more we need to personalize guidelines and recommendations because our patients most of the time, they don't fit the stereotypical patient that we see in clinical trials, in clinical studies, because those are average patients. And we need to tailor our approach to the patient that we have in front of us. We have patients that are that have more comorbidities, that are more frail, that don't behave like the patients that we see in clinical trials. So, although it is important and evidence-based medicine is fundamental when we talk about treating our patients, in the end, we'll have to tailor our approaches to the patients that we have in front of us. We can't treat the same way an 82-year-old patient with hypertension, dyslipidemia, diabetes, chronic kidney disease, the same way we would treat a 62-year-old patient with no comorbidities. Even though the guidelines say we treat them the same way, in clinical and real life practice, we can't treat them the same way. So we have to adapt our way of treating our patients, and therefore, if we need to treat them a different way, we need to spend different kinds of money with them, and we need to understand the different the difference that different approaches will imply.
The impact, yeah.
Yes, the impact of different approaches. So although the general way is good to understand, we also need to particularize more and more because patients will also demand that.
Yeah, and if I may add, George,
Yes.
because we are, well, in the day-to-day, we are looking more to the patient and less to the disease,
Yes.
right? So we need to individualize everything that we do.
Yes.
Okay, a lot of questions. So the second question is, what were the main challenges in implementing CardioFollow AI? Do you want me to read them all, or do you want to answer
No,
each one?
I'll prefer to answer one
Okay,
at a time. I think it's easier so as to not lose our focus. So the main issue that we have for us were two, essentially. One was the human resources, because although we do this every day, that means treating patients, following patients, this it was for us more exigent because it would increase, as I've shown you, the data load, the workload for everyone involved. So that would mean that me and all the nurses, we would have to do what we were supposed to do and more. So and that would mean that we would spend extra time following our patients, catering for our patients, doing more than our daily workload, and that was for one of our main problems. Also, that the public health system is not adapt in technologically to implement this kind of technological programs.
Mm-hmm.
So in terms of software, hardware, dealing with all of that was also an issue. Computers that are 20 years old and do not support the kind of internet that we need, everything like that was a really difficulty for us. Yes.
The second part of the question is, how much did you struggle to keep patients engaged, taking into account follow-up went for so long after surgery? And how much of a hurdle do you think patient engagement is to this kind of approach to healthcare, this kind, well, value-based approach?
So our approach was to make the patient the center of this program. So we explained to the patients the importance of this and what they were to gain from all this. And I can say that more than 90% of our patients were extremely engaged in this kind of activity. They understood they were being part of something different, something new, and something with the potential to improve healthcare for all of cardiac surgery patients. So they were really interested and really engaged. For us, it was also a concern, the fatigue that this kind of intervention poses on patients. So we were following them for 90 days, but they were only supposed to do daily measurements for 30 days and then weekly measurements up to the 90 days. However, if there was by any chance any change in clinical status that would imply a change in medication, a consultation appointment, something like that, we would then return to the daily follow-up monitoring to make sure that was a stabilization of the patient before going back to a more distant weekly follow-up. Okay. And the last part of the question was?
Let me just get back to it. I was just reading others, sorry. How much of a hurdle do you think patient engagement is to this kind of approach?
I don't think it is ever a hurdle. I think that patients are very keen on working with healthcare professionals. I think it makes them feel safe. And as they were feeling safer and safer to know that every day there was someone that was going to check up on them, even if we didn't call them every day, but they knew that we were monitoring how they were feeling, how they were improving, how they were taking their medication. So they felt safe and they felt that they
Monitored
needed
somehow,
also to
maybe.
give back.
Mhm.
Okay, so they were really engaged and trying to make this work for them as well.
Yeah, thank you. We have, let me just, okay. Next question. Very interesting presentation. It was actually a bit counterintuitive to me because we tend to assume that digitally driven solutions can help with the insufficient number of healthcare professionals. It just reinforces that we have to start measuring what we are developing. You also mentioned how this can have a positive impact in digital literacy of patients. Do you have measures for this impact?
So I can understand how this can seem counterintuitively, but how everything that the patients were introducing into this system, that means every measurement, every answer to the questionnaire, it would be expected of the patients from us to every day check up on them. So that was in itself, it gave us in itself more work than just making sure that they were doing everything. Because if we were just checking if they were doing everything, I think probably we would have less work. But as we were checking on how they were doing, it ended up giving us more work. Okay, especially because we were doing it on top of all the work that we were normally doing. We were not comparing people that were only doing this, only this service, and only following patients in this service with people following the patients in the normal pathway. No, although the patients were on different pathways, us, the clinical team that was surveilling them, were on both pathways. And like that, we were having extra work, and it ended up for us to add on to our workload. But I can say in the name of everyone involved that it was a pleasure for us to work with this kind of technological approach and new technology. Everyone was excited because we knew we were working to improve patient experience. In terms of patient literacy, we didn't formally evaluate patient literacy because it's difficult to find tools to do that. But in our satisfaction questionnaires, more than 95% of patients answered that they felt they were learning more about their health, that they felt that the fact that we were taking into account their experience and their help in following themselves made them feel safer and made them feel like they were contributing to how they were improving after surgery. Okay.
Thank you. I think you already answered this next question, but Do you also study and analyze the satisfaction of the healthcare professionals regarding the usage of the telehealth system? Because value also needs to be perceived by the professional, and you already answered this, that is using the technology to provide care. I don't know if you want to add something.
Yes, we didn't formally evaluate our satisfaction, but we felt very rewarded, especially when we saw how patients answered to the satisfaction questionnaire regarding the digital health service. It was really meaningful for us to see that patients were engaged in this and that they also felt and they told us that they never felt this to be a burden. Even though they had to measure this every day, for them, it was not a burden at all. And when we compared with patients that were on the traditional follow-up, almost more than three-quarters of these patients, they answered that they wished they had been followed more closely. Okay? So for us, it was really rewarding to see that all the blood, sweat, and tears we were driving into this was really
Worth it.
valued by our patients. Okay.
Thank you. And one last question regarding the first question that this same person asked. In your opinion, are we prepared for this custom-oriented healthcare?
In my opinion, I don't think we are prepared for it yet. I think that we have a lot of groundwork to cover regarding patient-tailored approaches, because as the problem is, in the end, even though we think we should tailor our approach to our patients, we also need to treat as much patients as possible. We It's also always an ethical dilemma for us to see if I do the most tailored approach to one patient, that means normally more costs. How many other patients I will not be able to treat the traditional way. Okay, so we have to take into account all this, and I would say that nowadays the healthcare system is still more willing to treat as much patients as possible. So it will always be a trade-off that we will need to know how to navigate. And like that, the importance of cost analysis, cost effectiveness, to see how well we're spending our money and how we can allocate our better our resources to treat the better way possible our patients.
Thank you, George, for all your answers. And Sarah, the stage is yours.
Yes, thank you, Carolina, and thank you all for the questions. And of course, to the speakers, thank you for this afternoon. I think it's been a very insightful webinar where we highlighted value-based pricing and cost analysis as key topics that are often overlooked in value-based healthcare. So I hope that this webinar has resulted in greater clarity and understanding for the audience. And to conclude this webinar, I'd like to say just a couple of notes. So I invite you all to follow L Cluster Portugal and IT Health through our online networks and social networks, of course, to know more about these and other activities that we are promoting. And regarding Digital PT, I invite you to stay connected with our Digital Innovation Hub. There are a number of services that we can offer for SMEs and public organizations. So I invite you to check the project, to follow your initiatives, and let's keep working together. And last but not least, I also invite you to check the next webinars of this series. The next session will happen next week on the 1st of April, and this session will focus on European regulatory frameworks on health data privacy and protection for developing and selling AI models for medical devices. The registration for this webinar is free but mandatory, and you can do that by scanning the QR code on the screen. So hope to see you there, and thank you once again for your participation today. Have a very nice week. Thank you.